Good evening, everybody. Thank you for your patience. We're just giving everybody a chance to join. This evening, we will be having, and I'm really excited about this, eosinophilic gastrointestinal diseases and biopsies. This is a hot topic. And I'm going to introduce our two speakers this evening. So I'm delighted that we have Margaret Collins coming across from the pond, somebody who I met many years ago. It makes us both feel slightly old, I think, I should imagine. First met Margaret Collins in 2004 when I went to Cincinnati, and she is a dedicated soul, is what I would say, who has basically dedicated her career to understanding eosinophils and the pathology. And she is a professor of pathology at Cincinnati Children's Hospital. That will be our first speaker this evening, followed by Associate Professor Yoni Savir, and I hope I've pronounced that correctly, who I saw speak last year on this great topic about the future of AI and eosinophils, and he has given us the pleasure of coming along this evening to share his expertise and insights that he's got on this topic.
To go here, so apologies, folks. Hopefully we're on our way now. Fulfilling the objectives of about biopsies, how many, where from, and why, and what you need to know about your pathology report and the value of standardized reportings, and finally current challenges in EGID pathology. And so why biopsy at all? For some diseases, all that you need is clinical history, a physical exam, lab tests. But for eosinophilic gastrointestinal disorders, or EGIDs, those aren't sufficient. Unfortunately, at the moment, there aren't any signs or symptoms or lab tests that are by themselves sensitive and specific enough to allow a diagnosis to be made with confidence. We have to have GI biopsies that show excess eosinophils in order to make the diagnosis. And the pathologist's role is to report the disease or lack of disease in the endoscopic biopsies that the gastroenterologists obtain. And pathologists receive small pieces of tissue and process that tissue, mostly to remove fluid, into a state that allows very thin slices to be cut and placed on glass slides. And here is an example of the process involved. So in the operating room, most people don't know this process. The biopsies are obtained by the gastroenterologist. They're placed into properly labeled containers that include the site from which the biopsy came, such as esophagus distal. There is a number that is assigned to those biopsies in the path lab, and a barcode is assigned as well. And that barcode is carried through the rest of the processing process, so that if by error a histotechnologist attempts to cut a different biopsy from what was in that jar, the machine that cuts the paraffin block locks. It won't happen. So the barcode is assurance that once the barcode is generated, this biopsy will be followed through properly in the process. The tissue is usually processed overnight. We can do it in a few hours, but overnight is the usual scenario. And the tissue is subject to graded series of alcohols, mostly to remove the fluid that's in the tissue. And then the next morning, what's called a paraffin block is created. The tissue pieces are placed in this block of paraffin, which I think is just simply candle wax, and a slide is subsequently cut. At the time that it's in the paraffin, and even when it's first, the tissue is first put on the slide, it has no color. So the next process, the next step then is to color the tissue on the slide so that the pathologist can see it. So this is an example of GI biopsies, not esophageal biopsies. I really don't think I could be able to illustrate those very well They are translucent, they are very pliable, they're very thin, and they're easy to miss, actually, in these containers. This is either stomach or colon, but there are 3 separate pieces here, and each of these will be removed from the container and put into its own paraffin block eventually, and whoops, and its own slide. And so here on the slide, we have what we call levels. So there are 6 levels on this slide. These are all the same pieces of tissue, but each one is different. Each level is different from the other on the slide. And for a disease that is patchy, like EGIDs are, it's important to have multiple levels to examine, because the number of eosinophils can vary significantly from, for example, the top level compared to the bottom level. And our custom is to cut 6 levels on a slide, and of course examine all 6 levels then. So the pathology report is part of a medical record, and patients are absolutely entitled to have their pathology reports. Many hospitals now have a site called My Chart, which is password protected, and which patients can access to get their their pathology reports. This is an older example of a report sent to us with slides from University of Cincinnati for consultation. What you want to do is be sure that you're looking at your pathology report, your name, your medical record number, or whatever you've got that is peculiar to you, and make sure you're looking at the right date. If you've had multiple endoscopies, you might, by happenstance, open up a report that was from 2 months ago or 3 months ago or a year ago, rather than the one that you're really interested in. And what you mostly want to see, once you're sure you're looking at the path report for the endoscopy that you've just had, is the final diagnosis. And here, this is fairly typical. The diagnosis begins with what tissue the pathologist is reporting on, such as duodenum, biopsy. So you know that what follows is about the duodenum, that there is the mucosa has no specific abnormality. That means it's probably normal. And there are scattered eosinophils. That's expected. The duodenum normally contains eosinophils. The stomach biopsy has mild chronic inactive gastritis. That's nothing to be concerned about, and rare. Eosinophils, no Helicobacter. That's a good thing to know. In the esophagus, again, reactive changes, negative for intestinal metaplasia, no eosinophils seen. So that's the part that you're most interested in the biopsy. And if there is anything that is unclear to you, you should contact, of course, your physician for clarification. Some path reports will also contain, before the final diagnosis actually, will contain what's called a gross and a microscopic description. Gross in the meaning that you can see it with your eyes. So what we just did with that container was a gross examination of the biopsies that were obtained by the gastroenterologist. Gross meaning you can see it with your eye, not that we're saying that there's anything upsetting or unusual or whatever about the tissue. It just, a better word would be macroscopic, but that word gross has been ingrained in the pathology literature. So, and microscopic descriptions, that's what, it's a word picture of what the pathologist has seen on the slide. And so the final diagnosis is what we just alluded to, and we use a combination of experience and pattern recognition, and sometimes cytology in the sense of a particular cell type. And for EGID, of course, that is the eosinophil. And the number of eosinophils in a biopsy is currently an important diagnostic criterion for diagnosis of EGID. And for eosinophilic esophagitis, the peak count that we look for is greater than or equal to 15 eosinophils in a high power field. It's not the best of criteria, but we've come a long way with 15 eosinophils in a high power field. Hopefully we'll have better metrics in the future, but for eosinophilic gastritis, greater than or equal to 30 eosinophils in at least 5 high power fields, and for eosinophilic duodenitis, greater than or equal to 30 and 3 high power fields, have been used in clinical trials, but what's being used in practice, in clinical practice, is really 1 high power field. We don't yet have criteria for the peak eosinophil count that is as well agreed upon for the rest of EGID as we do for the esophagus. Everybody accepts 15 eosinophils per high power field as the criterion for eosinophilic esophagitis. This is a table from a paper that was published in January of 2024 about children and recommending the threshold value for a diagnosis of EoG and EoD and enteritis and eosinophilic colitis and so on. Please don't look at the numbers in the right-hand column because they're scary. They scare me to look at them, but because they're per millimeter squared, which is bigger than a high-power field. So the numbers in the middle there are the numbers that the people who worked on this using literature review and experience and so
maybe
agreed upon. So for the stomach, greater than or equal to 30 in 1 high power field. I'm not sure that's the best number, but we'll see as time goes by. Greater than or equal to 50 in the duodenum, I think, is probably okay. Greater than or equal to 60 eosinophils in 1 high power field in the terminal ileum for a diagnosis of eosinophilic ileitis, I think, is okay. And then for the colon, 100 in the right side of the colon, 80 in the transverse and descending colon, and greater than 60 in the rectosigmoid are probably good threshold values to use. They're based on not large numbers, but based on the what's in the literature about what the peak counts were in what we believe to be normal biopsies. So all of the EGID or patchy diseases, eosinophilic esophagitis is for sure, eosinophilic gastritis is, and I think it's even more patchy than eosinophilic esophagitis. So to increase the diagnostic yield, it's been shown that for eosinophilic esophagitis, we need at least 6 different pieces of the esophageal mucosa to be sure that we'll find an area that's got at least 15 eosinophils per high power field in it. And for a diagnosis of eosinophilic gastritis, at least 8 pieces are recommended, 4 from the antrum of the stomach and 4 from the body of the stomach. And for a diagnosis of eosinophilic duodenitis, at least 4 pieces, 2 from the second portion of the duodenum, and 2 from the third portion of the duodenum. And so to diagnose eosinophilic esophagitis, we need both clinical symptoms and abnormal esophageal biopsies. All of these are clinical pathologic diagnoses, clinical symptoms, and abnormal biopsies. All consensus recommendations from the beginning cite 15 eosinophils per high power field. But even though, especially in the first consensus statement, there was a lot said about the additional abnormalities, that we didn't really deal with them until the histology scoring system was created. And standardized reporting of microscopic abnormalities has a number of advantages. Probably the most important is comprehensive and consistent evaluations. that track the evolution of the disease, that evaluate the impact of various therapies on the disease, that can help reveal aspects of disease pathophysiology, and so on. And so for eosinophilic esophagitis, we have abnormalities now in the scoring system that can be and really should be evaluated every time there is a biopsy obtained for eosinophilic esophagitis. So the bar there in the middle of the photograph is indicating really thickened esophageal epithelium. Basal zone hyperplasia is what that is called. And the epithelium normally was probably half the thickness of what you're seeing there. The arrows are pointing to eosinophils. There are a lot of them, more than we can see at this power, actually. Arrowheads are pointing to dilated intercellular spaces. You shouldn't see the spaces between the cells. We'll see them better subsequently. The asterisks are marking fibers in the lamina propria. The fibers should not be that thick in the lamina propria. And that's an indication of a potential fibrosis in the lamina propria. Here we see the eosinophils much better. The white asterisk is on top of a very large eosinophil abscess. The arrows are pointing to eosinophil surface layering along the right side. Their arrowheads at the left are pointing to dilated intercellular spaces. And here along the top, the arrowheads are pointing to epithelium that's more pink than the rest of the underlying epithelium. And the surface epithelial cells are more pink. It might be because they have more keratin in them. It's almost like a callus on your hand. There are eosinophils that the arrows are pointing to, and the thin arrows are pointing to the dilated intercellular spaces. You might be able to see little feathery connections between the cells. Normally, you need electron microscopy to see that, but these are so dilated, we can see them easily here. And finally, the arrows are pointing to what are called dyskeratotic epithelial cells. They may be indicating that someone has an immune disorder. We don't know that for sure yet. And so what does, why do this? Why pay attention to these things? Well, we found out that basal zone hyperplasia is really a master regulator of EoE pathology. Those epithelial cells secrete a whole lot of things that we didn't know about before we started studying eosinophilic esophagitis, including the substance that draws eosinophils from the circulation into the tissue. And basal zone hyperplasia may be responsible for persistent symptoms in patients who have ongoing symptoms even after eosinophils have disappeared. So they're a target for therapy, probably. The dilated intercellular spaces reduce the impedance across the epithelium and allow antigens to get into the epithelium of the esophagus. That's not good. And that too can be a cause for ongoing symptoms in patients who don't have eosinophils in the epithelium anymore. They are very persistent, dilated intercellular spaces. Surface epithelial alteration and dyskeratotic epithelial cells predict lamina propria fibrosis. And this is important because a lot of biopsies don't have any lamina propria attached. And if they do, it's crushed by the pinching mechanism of obtaining the tissue. So it's unevaluable, actually. But the other two things are they're evaluable in just about every biopsy that's obtained. So that's a backwards way of having an idea of whether someone is developing fibrosis or not. And then down at the bottom, all of those features, and the first one, furrows, is an endoscopic feature, but putting all of those features together has a very high ability to predict active eosinophilic esophagitis. And so moving on to eosinophilic gastritis, there are here along the top, all that red along the top here are sheets of eosinophils that don't belong there at all. The highest count in the normal biopsy is 10 or 11 eosinophils in a high power field. There are many more than that here. And it happens in this particular case that we had also the deeper part of the wall, the muscularis, to look at the muscularis propria, and that too was heavily infiltrated by eosinophils. So in EGID, eosinophils can be heavily infiltrating any part actually of the GI wall. And this is actually stomach, but honestly, if I were to look at this without having been told where it came from, my first thought would be the duodenum, because there's something along the top there that's sticking up the way that a villus sticks up on the surface of a duodenum. But actually, it really did come from the stomach, and it is markedly altered. There are lots and lots of eosinophils in that biopsy, and the crypts, instead of being straight up and down, are twisted and curled and at various angles and so on. So we know from the work of Dr. Hirano that there is a correlation between the endoscopic appearance, the endoscopic appearance of the stomach and the peak eosinophil count in the stomach. And we also now know that the features that we score in the stomach, sheets that are collars that are hugging the outside of the glands, eosinophils in the surface epithelium, eosinophils in the gland epithelium, eosinophils in the muscularis mucosa, and lamina propria smooth muscle hyperplasia. Right along here, these are all atopic or T-cell related lymphocytes that are in the gastric mucosa, and the red in particular show very strong correlations with the abnormalities that we're scoring in gastric biopsies. So hopefully we will discover pathways that can be exploited for therapies. And the differential diagnosis in eosinophilic gastritis includes anisakis, which is a helminth found in fish. H. pylori gastritis can have a lot of eosinophils. Collagenous gastritis is a disorder where there's thickening of the collagen under the epithelium, and atrophic metaplastic autoimmune gastritis is another unusual form of autoimmune gastritis, but it can, at an early phase of its life cycle, have a lot of eosinophils in the lamina propria. So moving on to eosinophilic duodenitis, then if I looked at this without knowing where it came from, my first thought would be that it came from the stomach, because the surface along the top there, that's the surface of gastric epithelium. This is so-called foveolar metaplasia. It just means that there's been a change in the epithelium so that it looks more like gastric epithelium than it does like duodenal epithelium. But it came from the duodenum, no villi, no trees poking up from the mucosa there, and lots of eosinophils, those red bodies in the lamina propria. And it's a faraway view, but here there are hardly any things that look like villi. The asterisk is marking a few across at the top on the left. The large arrows are pointing to a lot of eosinophils in the lamina propria. There are smaller arrows pointing to eosinophils in the muscularis mucosa, and arrowheads are pointing to eosinophils in the submucosa. Normally, eosinophils are not found in the muscularis mucosa or the submucosa in practice. And this is a study that showed that the transcriptome, the manifestation of gene changes in the duodenum, both upregulation and downregulation, that are depicted on the right side of the transcriptome at the bottom of the slide there. That transcriptome becomes more and more apparent at around 50, 52 eosinophils per high power field. So the recommendation that we saw earlier for a cutoff of 50 as a marker for eosinophilic duodenitis is probably a good starting place, at least, for exploring eosinophilic duodenitis more. And the differential here is hypereosinophilic syndrome, vasculitis, connective tissue disorders. Interestingly, H. pylori affects the duodenum, and it usually, or hardly ever, does it cause the eosinophil infiltrate in the duodenum that it does in the stomach. Giardia is another bug that does cause, it can be associated with some eosinophil infiltration in the in the duodenum, and inflammatory bowel disease as well can be associated with eosinophil infiltrates in the upper GI tract. And so eosinophilic, did we do that slide? I think that's the one. Whoops. Okay, so eosinophilic, all right. Differential diagnosis of eosinophilic colitis is very broad. Inflammatory bowel disease is probably the most important of those to explore and rule out. It's more common in children that they, early in their disease, in their inflammatory bowel disease, ulcerative colitis or Crohn's disease, they have biopsies that show a lot of eosinophils. It's less common in adults, but it's a conundrum in either age group to know what to do exactly at that point, other than allow the disease to declare itself over time. Lymphocytic colitis and collagenous colitis, we're finding also can be associated with a lot of eosinophils. Patients who have had transplants, probably because of drugs that they receive for their transplants, also can develop significant eosinophil infiltrates in the native and the transplanted organs. And Hellman's, of course, infections, systemic mastocytosis can be associated with a lot of eosinophils as well. Here, it's the same story, a lot of eosinophils in the lamina propria. Arrowheads are pointing to eosinophils at the edge of some of the crypts. On the left-hand side, there are a lot of eosinophils in the lamina propria, and a lot also in the epithelium of some of those crypts. On the right-hand side, there's evidence of crypt destruction, which can lead to loss of crypts. And it's a very busy slide, but on the left-hand side, there are brown cells in panel C. There are brown cells, brown staining cells. They're all in varying stages of the cell cycle, not resting. So they're either on their way to or from mitosis. And the top one is normal. There is a lot of mitotic activity normally in the GI tract. A Crohn's disease with a lot of eosinophils, and at the bottom there's active eosinophilic colitis. It's completely different from the normal and the inflamed Crohn's disease. And on the right-hand side, there's a marker for apoptotic cells, which is completely different from mitotic activity. And it's hard to see here, but there's more of that in EOC than there is in normal or Crohn's disease biopsies. And there's more evidence than this that the eosinophilic colitis is different from eosinophilic esophagitis, eosinophilic gastritis, and eosinophilic duodenitis. Genetically, it doesn't have the same atopic gene dysregulations that are found in those other disorders. So that's a bit of a surprise. It looks like an EGID, but genetically it's different. So we need to explore that. And finally, mast cells. This panel B is from a publication, a recent publication about mast cells and diseases and so on. And all of this here is populated by mast cells. And that's the GI tract, the colon biopsy, as a matter of fact. And here there's a stain for mast cells, as CD117 it's called. Here is a tryptase, which is more specific than that. And here is a stain for that stains only abnormal mast cells. And here this is a more typical picture of mast cells in the esophagus. This is a normal esophageal biopsy. There's one mast cell in the epithelium. There may be two in the underlying lamina propria. And this is eosinophilic esophagitis, where there definitely are more mast cells than normal. And observational studies suggest that mast cells contribute to symptoms in eosinophilic esophagitis, but a recent clinical trial using an antibody to CD117 did not show a reduction in symptoms or endoscopic scores for dysphagia, unfortunately. But I think that's not a reason to become discouraged about continuing to pursue what mast cells are about and where they what they're up to in EGID. This is a graphical abstract of a study that one of our young faculty performed using machine learning, as we'll learn more about shortly, in which she found that in the normal esophagus, the mast cells are usually in the lamina propria. When there's active eosinophilic esophagitis, they move from the lamina propria into the epithelium. And then in remission, there's a bit of a reversal, but the mast cells continue to be elevated in the epithelium, and that may be why they are contributing to symptoms. So what's the challenge in EGID pathology? Eosinophils are important to the diagnosis of the EGID in various GI tract locations. We have to come to consensus about what the peak eosinophil count threshold level should be for children and adults. Should they be the same number or not, and so on. We have to find out what eosinophilic colitis really is. Eosinophils don't always correlate, as we know, with symptoms, and that correlation is currently required for clinical trials. So we need to find a different metric to include in the clinical trials. And we need to utilize AI to analyze biopsies, to predict outcomes, and so on. And I just returned from the annual meeting of the College of American Pathologists, which it was announced at the meeting that the CAP has formed a partnership with the Coalition for Health AI. It's an organization I'm not very familiar with, but it also has a partnership with the Joint Commission, which is an organization that inspects all the hospitals in the United States. And they're hoping with CAP to form a partnership that focuses on creating standard practices of AI in pathology and so on. So AI and pathology are now real partners, and we hope to find out certainly more about that from Dr. Sevier. So thank you so much for your attention and for the opportunity to speak with you.
Thank you, Margaret. So, Margaret, if you'd like to click the green share button at the bottom. And now if we'd like to switch over to Yoni, that would be fantastic if you would like to share your slides.
Thank you, Amanda. Thanks, Margaret, for such a great talk. So it's great being here this evening, and I will try to give a talk that has a little bit of introduction, but also delve into the gist of how can we harness AI for eosinophilic diseases, how to improve treatment, improve diagnostic, and so on. So first of all, I guess everybody heard about AI. It's such a buzzword these days. Everybody's using their favorite AI tool. But when we come to medicine, AI is been, running for at least 10 years now. And the main needs is that we want to do layers or hierarchies of demands that we want from the machine. So the first one is to automate the procedures. So we saw a lovely introduction to how counting eosinophils is so important. Can we take this task, which is laborious and requires a lot of expertise, and make it automated, and it will be faster, more accurate, cheaper, and so on and so forth. So that's the first layer. The second layer is, can we use this automation to create predictive models? Okay, can we use this information that we are now harvesting to make better biomarkers, better causal models? And the third level is, can we reveal new insights? So we don't just want to give a prediction, you are sick, you are healthy, you need treatment A, you need treatment B. We also want to know why. Okay, so these three layers is what guide us in developing AI tools in general. So there's still a lot of challenges these days. And although we have a lot of advancement, still challenges that are pretty critical and fundamental. The first thing is that we have multiple data modalities. So we saw how biopsies are important. These are basically images, but we have a lot of other data, sequencing, a lot of other physiological measurements, and we have to learn how to put them all together. A huge challenge that we have is the imbalanced data sets that we have. So it's very easy to take a data set that is being measured in the UK and get a wonderful AI system that will not work in the US, in Cincinnati. Okay, so we really have to be accurate and try to take as general data sets as possible to make it generalizable. And then fourth main thing is that we want the AI to be clinically relevant, okay? Not just to make predictions that are meaningless. We have to tie it to a very concrete clinical decision. So as I said, multiple data modalities, what does it mean? Okay, so we have a lot of information that is being integrated into a decision. So we heard about histology. This is one type of medical image that we have. We also have CT, MRI, all the radiology images. We have all the text, all the reports, okay, that we need to scan and process. And we have a lot of omics data, the genomics, our DNA, transcriptomics, what is our protein million, so on and so forth. We really have to put it all together. And towards the end of my talk, I will try to highlight how this is really the frontier in eosinophil disease. How can we integrate all this data together? So this is the cycle of AI that we want to actually deploy in any type of disease, and I will try in the next 15 minutes or so. I'll try to keep it brief. I'll try to show you how we deploy this type of cycle in EoE. So the first thing, we want to capture the gold standard, okay, what the physicians are doing. Then we want to go beyond the physician and try to discover novel biomarkers. Then we want to connect them into treatment, Okay, it's not enough to discover biomarkers. We want to say something about treatment. And then we want to integrate more data and do it all over again. Okay, so where are we with regard to eosinophilic diseases in general? So I will give EoE due to the limitation of time. I will focus on EoE as an example. So I guess most of you aware to the EoE, an autoimmune condition with really a huge impact on life quality. And the main way to characterize the disease is, as we heard so beautifully in Margaret's talk, is to look at the biopsy, look at a certain area, the high power field. It's a term from microscopy that just tells us a certain area. And we ask ourselves, in this certain area, how many eosinophils there are. And you have to understand that this procedure is very general. So there are many, many, many conditions, cancer, other autoimmune diseases that are actually based on this procedure. Let's look at a certain area and ask questions about the density of cells. In our case, it's eosinophils. So if we have more than 15, we declare the patient as active. Less than 15, it's not active. And so what we did in collaboration with SEGIR, which is the consortium of eosinophilic disease researchers, and with Cincinnati Children's, and of course with Margaret herself, which contributed a lot to this work, we were trying to see how can we harness AI to improve EoE diagnosis and treatment. Okay, so let's start with the first step. So we want to capture the gold standard. And what the gold standard is? Well, we want to know whether there are more than 15 eosinophils in a high power field. We have more than peak eosinophil counts of 15 or not. That's the gold standard. Can we recapitulate it with the machine? And the question is yes. So what we've done in the last 2 years, we built an AI platform, which is called PECNet, which actually take the whole slide image that we talked about before, do a lot of AI processing, and the end of the day, count the eosinophils and can provide very fast and very accurate how many eosinophils there are. So what you can see here in this slide is a comparison to what the pathologist is marking as eosinophils, that's the ground truth, and what the machine is predicted to be the eosinophils. And what you can see in this graph is comparing the human to the machine. And you can see that the counting of both machine and the pathologist is pretty similar. Okay, so there's a very, very good fit on the identification and counting of eosinophils. So that's very cool. Can we take this property and translate into making a clinical decision? And the answer is yes. So if we use this pipeline, the PECNet pipeline, to classify patients according again to the gold standard of whether the patient has more than 15 eosinophils per high power field or less, we can see that we get an accuracy of almost 95% and sensitivity and specificity of also 95%. These are all different metrics that are telling you how good the machine is. Okay, and this is very good results. And these days we are now deploying it to real life challenges in the hospitals themselves. And I hope that in the next year or two, it will be actually a tool that pathologists could use around the world. And so that's very nice. We have a tool that can capture the gold standard and can tell us what the peak eosinophil count. But now we have much more than that, right? Because now we don't have only, one number that tell us, okay, in this biopsy, there's more than 15 eosinophils in this area somewhere along the way. We actually have now, since we can do it systematically and very accurately, we have the entire eosinophil distribution in the entire slide. So what you can see here is the tissue on the left, and on the right, you can see the eosinophil's density along the entire tissue. Okay, so you can see that the distributions are different. And what we asked ourselves, can we now use this information to say something interesting about the disease? Okay, and that's the second stage. We're able to capture the gold standard. Can we now, when we have this abundance of information, can we infer novel biomarkers? Okay, so we added another cellular feature, which again, Margaret mentioned before, which is the basal zone. And now we have 3 parameters that characterize the tissue, 2 types of eosinophils, and the basal zone area. And based on this, we have the entire distribution along the tissue. So that's what you can see here. Again, this is the tissue, just the image of it. And what you can see here is the entire eosinophil distributions and the basal zone distributions. So you can see we have now the full map, the hills and valleys of the cellular features. And based on that, we were able to extract more than 70 scores that describe this tissue. So now instead of having 1 score, in the case of the PEC, we have now 70 numbers that describe the tissue. And based on these scores, we were able to infer 4 new novel biomarkers that, using them, we were able to improve the severity prediction of patients. I will not get into all the details of these figures. This is quite a convoluted figure. But the main point is that by capturing the gold standard, that's what I showed you before, we were able to predict whether a patient is EoE active or not with 95% accuracy. And now, using these new biomarkers, we can go an extra step and predict the severity, which also tells us something about the susceptibility of the patient to treatment. Okay, and we are able to capture this severity with an accuracy of 85%. So what this highlights is the importance of going from just recapitulating what the pathologist is doing to try to infer new biomarkers. So that's very cool. We captured the gold standard. We can now automate the process. We use abundance of information to infer biomarkers. Can we now use it to couple all this information to actual treatment? Can we now promote personalized medicine? So this person could get treatment A and the other one treatment B. So what are the typical treatment in case of EoE? So we have, as a first line, we have dietary management. Steroids are also, it can be given as a first, and PPI approaches, first approaches. And we have endoscopic dilation, which is, of course, cause a lot of uncomfort. And we have also the new generation of immunological drugs that are now entering the market. So we wanted to focus on the first line of treatment, which is the dietary management, because that's where we can maybe promote the most help, especially for young children. So what is the main dietary management? It's dietary restrictions. So you take allergen and you remove it from the diet in hope to remove part of the symptoms. So what we did, we took data from a clinical trial that actually asked the following question. What is better? To take a person and to eliminate 6 foods from her or his diet, which is milk, wheat, eggs, soy, fish, and tree nuts, or maybe we should just start with one food elimination diet, which is just milk. Okay, so in this trial, there were around 100 people. Half of them got the one food elimination diet, one fed, and half of them got the 6 food elimination diet, the 6 fed. And during this treatment, the data was collected, and the question was, what is better? And surprisingly, or maybe not surprisingly, well, it depends who you're asking, the effectiveness in terms of a decrease in the number of eosinophils after 6 weeks was very similar. So whether you got a 1 food elimination diet or 6 food elimination diet, about a third of the patient saw some relief. Okay, so this is kind of disappointing. Okay, there's no significant difference between patients who got 1 fed and 6 fed. So we asked, can we use all the information that we have from the AI to maybe personalize the treatment based on the histology of the patients? Okay, and this type of exercise is very hard, and I want to say something about how important it is to understand the difference between correlation and causation. Okay, so if we see that something, parameter A is correlated with parameter B, it doesn't mean that it causes it, right? There could be some confounding factor along the way that actually is underlying the correlation that we see. And this is also important to distinguish between causation and correlation when we try to do trials. So what would be the ideal case? I will take the same patient, I will duplicate it, as much as I can, give 1 copy treatment A, 1 copy treatment B, and then see the response, right? And this will give me the perfect understanding of which treatment is better, right? The problem is that this ideal case cannot exist, even in identical twins, right? We just cannot do it. So what's the best we can do? We have patient A, and we give him treatment A. Patient B gets treatment B, and we try to make patient A as similar as possible to patient B, okay? But it's never perfect. And these differences is the main point, is the main thing that we try to get over when we use causal learning, okay? How to distinguish between causation and correlation that arise because of the confounding factor that always happen when we give different persons different treatments. So we took all the features that I showed you before, and we try to use this information to see if we can make a better prediction. Now, this graph looks complicated, but it's very simple, and I would like to spend 2 minutes to explain what you see here, because it's very important and highlights the beauty of using AI for treatment selection. So what you see here, all these bars are measuring the effectiveness of treatment. So what you see here in the blue and in the orange is the effectiveness of giving 1 food elimination diet or 6 food elimination diet. So if I get a patient, I give him 1 or 6. And as we shown before, the effectiveness is only around 30%. Only about a third of the patient will experience reduction in their eosinophil count. Now, what you see here in this green band over here, this is actually the effectiveness if I flip a coin when I get a patient. So if I have a patient and I know nothing about him, I just flip a coin and say, okay, you get 1 fed elimination diet, you get 6 food elimination diet, totally random. You can see that you can get around 30%. So in this sense, giving 1 fed or 6 fed is as effective as flipping a coin. And the nice thing is that what you can see in the yellow bar is the AI assignment policy. So the AI gets the biopsy, calculates all the 70 scores I described before. And based on this, say, you decide whether the patient should get a 1-fed or a 6-fed. And in this case, we see that the effectiveness is now almost 60%. Now, at the first glance, 60% looks like a low number, right? After all the 90% I showed you before. But you have to remember that 60% is almost double what just giving 1-fed or 6-fed just by random or just by giving this or this. So this is a great example on how AI can really improve the food elimination assignment based on the features I showed you before. So that's great. Again, we captured the gold standard. We inferred novel biomarkers. We used all this information to have a decision support system that personalized the treatment. And now we want to go beyond the histology images. We want to now maybe integrate more data. And the main data that we want to integrate is genetics. Okay, so when a patient's come and we have the biopsy that you showed, that Margaret showed before, what we can do is just to take a slice and make the image, the histological image, but we can take this tissue and we can also infer from it molecular knowledge about how many proteins there are, what is the mRNA that in the biopsy. And what we want to do is put it all together to improve prognosis and condition. The other thing that we want to do is, because this arrow of sequencing or inferring the molecular data can be expensive and not available in all hospitals, what we want to do is also, we want to take the biopsy, learn relations between histology and, let's say, proteins or mRNA, and then just based on the histology, improve prognosis and condition. And here is an example of how to do it. We used a data set where we have both the images, the histological images of the tissue, and we also have the mRNA. mRNA is the instructions on how to make proteins that are being transcribed from the DNA. And we use these two features to improve the endoscopic reference score that physician gives based on filming the esophagus as they do endoscopy. So just to summarize what I've shown you. So I've showed you that we are now in a very good place with harnessing AI to EoE, and now we are going to now hopefully also expand it to EoG in the next year or two. We are able to capture the gold standard, so now we can automate the process of counting eosinophil. We can use this rich information to infer novel biomarkers, and we can use these biomarkers to improve treatment selection. And in future work, we're going to take, this methodology and apply it also to EoG and other eosinophilic related diseases. So I want to thank everybody who actually did the work, and I'll be happy to take questions later if you have some.
Thank you so much, Yoni. It's a huge topic, and I think you did really well to give us a whistle-stop tour and an insight to the work that is coming along in the world of medicine in quite a speedy way, I think, because things can take a whole lot longer in other fields.